So Megan's making more handouts. If we need it, just let us know that you need one, or come over here and she'll make you one. So those of you, I know a lot of you, there's a few faces that are new to me. So my name is Becky Miller. This is Meghan Kattner. We're both in the billing department. I do some of the compliance stuff with documentation and medical billing and things, and Meghan does a lot of that as well. We both audit charts and things like that. And so this is our first lunch and learn meeting, and we've been really excited about it. And given the circumstances, it's been a little tough. So I really appreciate that you guys are here, given everything else that's going on. So thank you guys so much for being here. And you'll notice there's a agenda that looks kind of like that without the yellow marks and stuff on it. That's what we're going to talk about today. It's going to be fairly quick. My goal today is to poke and provoke you for questions and things like that, so that we kind of know what you guys need for the next meeting too. So we want this to benefit everybody. So I don't want to talk to just one group or or one clinic. This is going to affect all of this stuff will affect everybody. So let's get started. So the first thing I want to talk about is just some basic documentation rules, basically. For billing office visits, we have to be very detailed in our documentation in order to meet certain criteria. So it's really important that we pay attention to these things. So why is it important for your doctors that you document things properly and accurately and in detail? Anybody?
So we can address the patient's concerns.
Yeah. So especially if you've got a chronic patient, let's say a glaucoma patient comes in and they need to know what their pressures were the last time. Obviously, we're going to have that in the chart. We don't see a patient without documenting pressures. But what about compliance with drugs? That's important for the doctor to know. If they weren't compliant before, they compliant at this visit. Did we change meds at the previous visit? And did we document that? And are we going to what is the efficacy of that drug now? What is the pressure now on the new med? So if we forgot to document that they changed medications, we're not looking for that. And we're going to wonder why their pressures are all of a sudden either down or up. So it's really important that we do that. So we're going to pay attention, really close attention. What did the patient complain of? And so we need to be thinking forward. What is the doctor going to need at the next time the visit is here? Not only that, but what is billing going to need? So why is the patient here? Are they complaining of anything? How severe are their complaints? If it's pain, are we getting it on a scale of 1 to 10? So we know what their pain level is the next time they come. We know if they're better or worse or the same. What was the diagnosis at the last visit? And did that change at this visit because of other things that we've noticed or other findings? What did the doctor discuss with the patient? That's very important to know from one visit to the next. What did the doctor discuss? Did they discuss different treatment options? What was the patient's reaction to those treatment options? Did they choose a particular treatment option, and if they were given a list? So those are very important things to have in the chart, again, for the next appointment. So what treatment options did the patient agree to? How this affects billing, so you know how it is going to affect your doctor at the next visit. So that's something you all are acutely aware of. But how does it affect us at that visit? If you go down to B on the list, it's all in the details as far as billing is concerned. We run into a lot of scenarios where we can't really count a certain diagnosis because we don't have the documentation in the rest of the chart to go along with it. And a lot of times, the reason for that is patient didn't complain about anything when you were in the room. Doctor walks into the room and they're, bleh. So they complain about everything under the sun. I don't know how many times you guys have had that. I've been a tech. I know I've had that happen. I can't tell you how many times that I can't elicit a complaint no matter what I ask this patient, and the doctor walks into the room and they've got all kinds of complaints. So, of course, when I teched, it was back on paper. It was really easy to go back and add that to the history in a paper chart. It's a little bit more difficult than an electronic medical record. But if that patient has a trichiasis, but that you got no complaints from them. They're here for an IOP check, but they have trichiasis. You've gotten no complaints from the patient because you don't know that they have trichiasis. You haven't done the slit lamp exam. So doctor comes in and he says, you have an eyelash growing the wrong direction. Are you having any scratchiness? Are you having any, and then they're like, yeah, the other day my eye was really watery and it really hurt. That needs to be documented in the HPI somehow. I don't know. That's up to you on how protocol and how to deal with that in the clinic setting. But we need that because if there's no complaint and no cornea involvement, we cannot bill that epilation that the doctor does at the end of the day, at the end of the visit. So we're doing same thing with punctal plugs. You've run into recently.
With punctal plugs, like if there's no complaint that's related to the cornea, such as dryness or irritation listed in the HPI, we are not able to bill that punctal plug insertion.
So we're giving some punctal plugs away, and again, this is mostly coming, I think, from patient not complaining to the workup tech, but then complaining to the doctor, or the doctor's. Go ahead. Yes.
What about post-operatively?
Post-operatively, it depends on what we're doing it for. A lot of times, like with a PKP patient, we're not going to get those paid if that's all they have. If the only diagnosis is that they're post-op PKP or DSEC, that is not a billable diagnosis. So we're giving those away. I think Dr. Robinson is aware of that, but he's going to take care of his patients anyway. So post LASIK, unless they're dry, we can't bill those either. But I think you guys generally do comp those anyway.
Okay.
Yeah. So there are reasons why we would do it anyway, even though we don't have a billable diagnosis. But on those patients with SPK, on those patients with, we really need to try to get a complaint out of that patient, because without a complaint, we have no medical necessity. We have not proven medical necessity without a patient complaint. So if it's something that the doctor intends to bill, we've got to document a complaint of some kind. Usually the doctor's able to elicit one.
The other thing we wanted to bring up is there are only certain diagnosis codes that are approved by insurance where they'll pay for like an epilation of punctal plugs. So like for punctal plugs, if you've got a patient who is just has like herpes virus, that's not a billable diagnosis. Even though there's a necessity to do the punctal plug to alleviate some of that pain for the patient, it's not recognized by insurance, and so that is not billable.
What about the herpes keratitis?
Well, that's a carrier issue. That we're not going to know until we bill it.
But for the most part, it's not.
Right.
Any diagnosis code that begins with B is not billable for punctal plugs.
Yep. And all of those, all of the herpes, the simplex viruses start with B. So.
Did you say V or B?
B is in boy.
B is in boy.
That's what I thought you
Like the B00.32.
Right. So, and I know you guys don't deal with the codes necessarily, but if that code comes up as a B, you can pretty much guarantee we're not going to get paid for the punctal plug. It may be the patient needs it anyway, and we're doing it. But again, we're mainly talking about when the doctor intends to bill the plugs. Let's get everything we can in a chart. If he intends to bill the epilation, let's get a patient complaint in the chart. Sometimes it's not possible. Sometimes you just don't elicit it, but the doctor wants to do it anyway to keep them from having cornea issues. So it's going to happen, but in order to get paid, we have to have something in all three of the key components. We have to have something in the history, we have to have the appropriate exam components, and we have to have the appropriate assessment and plan. So it has to be something in all three places that correspond to that diagnosis and that treatment plan. So does that make sense? Okay.
So quick question.
Yeah.
So while scribing, say the doctor elicits a complaint, but it's pretty minimal. It's like, so has this lash been bothering you? And they're like, yeah, I guess so. Is that translatable into complaint?
Even a slight complaint is translatable.
Okay.
You can put that in the chart,
Okay.
and you want to do that, especially if the doctor's going to assess that problem.
Okay.
If
So it's not stepping our bounds to say patient bothered by.
No,
No.
absolutely not.
All right.
Not at all.
Nope. That's actually a really good practice to get into. So that's a good transition to that third part to C. And the chart must make sense. So all three key components. So patient comes in, I'm gonna give you a couple scenarios. Like I said, I'm gonna go through this quickly because I wanna elicit questions from you guys. Patient comes in for an IOP check. Doctor you do everything you're supposed to do, no complaints, or compliant on their meds, you know. You do the history, the chief complaint and the HPI and all the history stuff. Doctor comes in and they complain that their eyes are burning, or some kind of complaint. Go back up and document that. So because you don't know what the doctor's going to find, you don't know. So you might as well document that. So the doctor's going to look at whatever piece of the eye, whatever part of the eye that corresponds with that complaint. So that's automatically going to be in there. The exam just automatically happens. They do a slit lamp exam on almost everybody, so that's usually a no-brainer. The assessment and plan, if you're a scribe, how many scribes do we have? Okay, so scribes, it's very important that if the patient complained of something, and there's something documented in that, you must provoke your doctor to assess it. So sometimes those little complaints get missed in the chart, and that we need to make sure that all three, if the patient has a complaint, there needs to be an appropriate exam element documented, and an assessment and a plan. Even if it's negative findings are that's an assessment. If they didn't find any reason for the patient's complaint, that's an assessment. So negative findings are perfectly fine in an assessment and plan.
What code would you encourage us to use for negative findings?
Patient complaint, the symptom, whatever the symptom pain in around the eye, whatever their symptom was, that's what you would put in your assessment.
I thought the way you said that so affirmatively, I thought there was a special.
Oh no, if there's no diagnosis,
that
yeah, usually
know.
there's almost always a way to code a symptom.
Right.
So you would code
Yeah.
the symptom in that point.
Okay.
But findings are fine. You can code findings. If that's all you have, you don't have a diagnosis to go along with it, code the finding. You don't want to code findings if you have a diagnosis to go along with it. So if the doctor has assessed it and determined a diagnosis, that's what you're going to code. Let's see. So it goes both ways. Either the patient has complained about something, and we need to make sure that is followed through the whole chart. So workup checks, when you're working the patient up, make sure you get all those complaints down. So the big question about this is, how does this affect billing?
We don't get paid.
Yes, exactly. So if the patient complains about something and it's not assessed, we don't get credit for that assessment. If the patient does complain about something later on in the exam and we don't document it in the history, we still don't get paid for that assessment. We can't count that because we don't have all three of the key components documented for that particular complaint. So it affects billing greatly, actually. So we just have to make sure that all three pieces are there. It's really 4 pieces if you want to think of it as a SOAP note, which we're going to talk about here in a second. So you've got your history, you've got your exam, and you've got your assessment and plan, which is kind of one, but really try to think of it as two different. You have an assessment, and then what are we going to do about it? So any questions so far? Does that make sense? Does it make sense? I don't see too many glazed over eyes, so okay. So, this handout right here, before we go on to SOAP notes, this I printed off of OMIC's website. Does everybody know what OMIC is? OMIC, I gotta read it. Ophthalmic Mutual Insurance Company. This is the group that will defend our doctors if they get sued. These are the lawyers and they only do ophthalmology and optometry claims. They specify very specifically. They have doctors and lawyers on board. I mean, these are some scenarios where documentation made or broke a malpractice suit. So they have scenarios where detailed documentation saved one, and they have scenarios where a doctor actually got a negative result in a malpractice suit because of lack of documentation. They've forgotten to document something. So this is we won't read this. This is a lot of reading, but I really highly suggest you go through this because you're going to recognize probably, or at least be able to identify with some of these scenarios. We don't do any of these things except for the good ones in this clinic. So, but let's make sure that we keep it that way. So I really highly suggest you read through this. I think this is a really, really good thing for you to read at your leisure. So on to SOAP notes. Before you look at your, nobody look at the SOAP notes thing. Somebody tell me what SOAP stands for.
Subjective objective assessment plan.
There you go. I did have a bag of Hershey's Kisses, and I would have thrown you a Hershey's Kiss.
That's all right.
Or pass it down, really, because that's really, really pass it down. But
Trauma codes.
maybe we should think of some other thing to pass down. But anyway, yes, that's exactly what it stands for. Subjective, objective, assessment, and plan. One of the things that is the most commonly misunderstood pieces of this is the assessment and the plan. A lot of people kind of lump that into one thing. It's all the same thing. Well, it's really not. So we'll talk about that. But let's briefly talk about the subjective and objective. Again, we have to have all of these pieces to be able to bill anything. And if these pieces are missing, it greatly affects the level of service that we bill. We may have to downcode something that the doctor thought he should get a higher level on, and we hate doing that. We want the doctor to get paid for what he does, and this is the way we make sure that he gets paid for what he does, is by documenting all of these components. So in a basic SOAP note, which is those of us that used to chart on paper records, which there's a couple of us, this is basically what we went by. I mean, this is how we documented in a paper record. We could document a whole exam on a blank piece of paper going by a SOAP note. We don't have to do that now, thank goodness, because we have electronic medical records who in some ways has simplified it, in other ways has made it more difficult, but it is what it is, so we're going to work with it. So, but just for the basic knowledge of what we need to bill something. So subjective, that's going to be your history components. That's going to be your chief complaint, your HPI, your review of systems, and your past, present, PFSH,
We got you.
past, family,
Social.
social history, sorry. So those are things, that's information you get from the patient. That's not us looking at something and finding something. That is all subjective. It's all stuff that we just get directly from the patient, information we obtain from the patient or the patient's family. Objective, that's our exam. That's easy, that's our exam. Those are definite findings. It's either there or it's not most of the time. That's kind of a black and white. That's why it's objective. The assessment and plan. And the reason I say assessment and plan is because frequently we combine those things together in our thought process. But let's try to separate that out in our thought process so that we can meet all of the billing guidelines and all of the things that our doctors need for the next visit. Because we're thinking forward to what does our doctor need for the next visit. So now you may look at your handout. So basically, I'm going to go right. I found this on Wikipedia. I'm not a big fan of Wikipedia, but I really liked their explanation of what a SOAP note was, because this is exactly how I was taught what a SOAP note was years and years ago. So the subjective component it starts on page 1. We already went over that. It's the chief complaint, the HPI, and all the other stuff. And you guys know how to take. You guys all take good histories. We all know how to take good histories, so we're not going to harp on that. So the objective, you guys all know how to do that. That's like I said, that was a no-brainer. The assessment. Somebody tell me what the assessment is. Okay, the assessment is basically the diagnosis and how the doctor came to that diagnosis. So it's the description of why the doctor thinks the patient has diabetic retinopathy. you can read that. It's basically just how did the doctor get to that diagnosis and what is the diagnosis. So basically it's the diagnosis and all that stuff that goes with it. The plan is basically the treatment plan. What are we going to do about those things? Are we going to do nothing? Are we going to watch and wait? Are we going to prescribe something? Are we going to do surgery? That's the plan. So they're two separate pieces. And it would be really nice to have the mindset that those are two separate pieces and not lump them together, because a lot of times what happens when we lump them together, we get a diagnosis and a treatment plan. We don't really get an assessment. So the assessment is really important because not as much from a billing standpoint, really, but for the on-call doctor that has to go look at this medical record. Why does the doctor, what was his thought process? Why did it, that's why we don't just put the diagnosis and be done with it. We need a little bit there, and most of that is on your quick plans.
I was
You have-
gonna ask that,
yeah.
because I mean, really, most of the time it just has the diagnosis, but when we print the chart note, it has exam findings,
Mhm.
and it has the diagnosis of diabetic retinopathy or what have you, and then we have our quick plans, but the quick plans usually say, discuss risks of this, discuss that.
Right.
It doesn't say diabetic retinopathy because,
Well,
you know,
right,
the exam
that's a bad
reflects that.
example, but,
I mean, but even the
Right.
corneal abrasion or something, you know, the exam will reflect
Well,
why they came to that conclusion.
right,
So are
yes.
are we missing, is what I'm saying.
Right.
Is there somewhere we're missing the mark?
A little bit.
Okay.
It's not horrible. Where we're missing it is so let's just read this. A medical diagnosis for the purpose of a medical visit on a given date. Of the note written is a quick summary of the patient with main symptoms. Diagnosis including a differential diagnosis. We miss that a lot. When your doctor orders an MRI, I'll tell you where this affects billing. Not necessarily our billing, but in getting pre-search for these things. Your doctor, this is the best example I can give. Doctor orders an MRI. We have no idea sometimes in the chart because there's no actual assessment why he's ordering the MRI. Sometimes we do, but if the doctor's trying to rule out something, that needs to be written in the chart. Even if you have to ask them, are you trying to rule out something, or do you have a suspected diagnosis? That's really important to just put that in the assessment, because we're asked those questions when we pre-cert these things. And sometimes we don't get them pre-certed and they go to peer-to-peer review because we don't have enough information in the chart. And doctors hate peer-to-peer reviews. Your doctors don't like that. None of them. There's no doctor in this clinic that likes to do a peer-to-peer review. They're a pain for them. And they're time consuming and they don't have the time to do that. So we would save them a lot of trouble if we would, if we're going to order radiology of any kind, CTs, CAT scans, if we're going to do anything odd, that's when this is really going to come into play in ophthalmology. A lot of our diagnosing, it's pretty, cut and dry. You've got a large cup disc ratio or asymmetric cup disc ratio. We've got high pressures. They have glaucoma, visual field defects, thinning nerve fiber layers. We know they have glaucoma. It's pretty cut and dry in the chart. There's not much of an assessment needed for that other than maybe medications, efficacy of medications. That's kind of going to go along actually in your treatment plan. But in the assessment, though, if something's not working, that needs to be in your assessment, because then in your treatment plan, you're going to change their drops, or the doctor is going to change their drops or something. So we need all of those pieces. But really where you guys need to really pay attention to our assessments, the actual assessment piece of that is when we're going to order something odd. And that's got to go somewhere else. Yes.
A lot of the defaults in the computer for the assessment are worsening, improving.
Yes.
So that's part of the
Yes.
assessment.
Yes,
right?
and that's important too. Okay, I'm glad you brought that up because that's not in my notes. That's an awesome point. So the way we bill things, or the way we quantify the medical decision-making piece of your doctor's exam has a lot to do with if a problem is worsening or getting better, if it's remaining the same, if there's no improvement. That needs to be documented in your assessment, not just the patient, the subjective part. It needs to be actual in the assessment. The doctor has decided that this is worsening. They get more credit for a worsening problem than they do a problem that is getting better. But that's important for the doctor to know too. So we need to know, but we need to know how to quantify that information. And if we have to assume that it's better if it's not stated as worsening. So if there's a problem that's worsening, definitely that needs to be in the assessment that that problem is worsening, because your doctor's not going to get credit if that comes up for audit for a worsening problem if it's not stated by the doctor as worsening, not by the patient. I mean, it can be partially start there, but it needs to be stated by the doctor to be worsening. If it's worsening, we don't want to state it as worsening if it's not. But it's important to know if it's not reacting to medications, if it's not improving, if there's no improvement with treatment, because that's going to make the doctor change the treatment plan. So the assessment is going to make the treatment plan make sense. If we change the treatment plan, but we don't have the reasoning in the assessment, the treatment plan makes no sense to the next doctor that's got to see that patient, the on-call doctor, if the patient has a problem. So very important for billing and for your doctor, for that to make sure that piece of it gets done. We're great at the treatment plans. Treatment plans look awesome. Everything's documented there. We've talked to the patient about it. The patient has agreed to this treatment plan. You guys are that's awesome. We need to just work a little bit on the assessment piece of it. Most of the time it's not going to matter, but there are times when it's going to matter greatly. So, any questions about that? Any questions overall? I have obviously not poked you enough. No.
When you get to the office visit, make sure.
Yes, okay. I actually had to pull this off of where I emailed it to you. I finally got my Outlook back.
I pulled mine off of that.
Yeah. So has everybody seen this before? Sometimes you'll see them in the little cards. I know some of you have. Okay, so
They are in the binders, in the exam room folders, in the drawer everywhere.
There's a copy for every person
Yep.
that's scribe trained.
So these are great for your run-of-the-mill patient. These are, when I would not use these, we'll go over how to use it here in a minute, but when I would not use this is if you have a patient with multiple problems that you're actively treating. This is not gonna work for that. Everything, your glaucoma patient, your macular degeneration patient, if that's all you're assessing, actively assessing and treating at that time, this is great to use. This is going to be 90% accurate. It's not going to be 100%, but no tool like this is ever going to be 100%. But this is one of the best tools out there for your patient that you're just seeing them for basically one thing. How this works. Okay, so let's do a new patient because that's up on the top. So under the assessment, you're going to decide if it's an emergency, obviously, or if it's serious or if it's a mild problem. So somebody give me a scenario and we'll just go through it.
Or you may,
Like what?
you're saying this is a new patient who walks in, they were worked in today
Right.
for a treatment or an emergency situation, so they got poked in the eye
Okay.
with a pencil at school.
Okay, so if poked in the eye with a pencil at school, let's call that an emergency right now because we don't know at first what's going on if the patient's had a penetrating injury or not. There's no status or change on the patient because they're a new patient first time we've seen them. Let's say the doctor found that they have a corneal abrasion from it, but there's no foreign body. There's just a corneal abrasion. They scratched their eye. So what is the doctor going to do? What does they typically do for a corneal abrasion? Antibiotic. So they're going to treat it.
Treatment.
Right? So they're going to RX it. So we're going to stay at the top of this. We're not going to ever go back up, but we're going to stay at the top where the line is. So we've gone to an emergency, but he doesn't need surgery or anything, so we're going to drop down to treatment because we've prescribed a drop, right? So what kind of exam does he typically do for that type of injury?
Just what they-
So that's gonna be